The following program is brought to you by the Center for Educational Outreach at Baylor College of Medicine.
Well, as you could tell from the introduction, I'm involved in genetics, and I will probably try to give you the impression that a lot is happening in genetics in autism, and I think that's exactly true. If we actually had a session like this 3 or 4 years ago, and there was a lot less known at that time, and I'll try to give you perspective about where we are about understanding the causes of autism. I'm just going to start with some non-genetic issues just to kind of let you know that it is important and there are possibilities. There's still a lot of autism that we don't understand. And there are certainly possibilities of environmental factors. There could be some kind of congenital viral infection or early childhood viral infection that we don't understand or know about. There's obviously a lot of press coverage about whether vaccines and thimerosal could be a factor. Sometimes if you listen to talks about how many chemicals we all encounter in our environment today compared to 30 years ago, it's absolutely frightening. And I'm sure there's many other things that we could think about. Most of the known things about what causes autism have to do with genetics at the present time, but there's a lot of different forms of genetics, and I'll say more about that. Now, there's been this question about whether there's an increase in the incidence of autism, and this chart, which shows about an 8-fold increase over some period of time, has come from the California Department of Public Health, and there's been a lot of discussion about this. There is no doubt that we give a diagnosis of an autism-related disorder to many, many more children than we did 20 or 30 years ago. When I was a resident in training, I don't know if I saw a single autism patient in all my residency, that is, a patient who carried that diagnosis. I'm sure there were many patients that would carry that diagnosis today. I think at this point, there's not a lot of growing evidence supporting this being a real change, but most of the evidence fits with it being a change in how we diagnose children and what kind of labels we attach. But this study in California had concluded at this time in 2002, the state had authorized a study, and this study sort of concluded that some, if not all, of the observed increase represents a true increase in cases of autism. So they were saying there really is a change, and I'm saying I don't see a lot of people that are convinced of that at the present time. But it's still a very big worry, because if there is a change, that means we could change something back and reduce the incidence and probably get some insight into treatment. But this is kind of an authority in this field who I just took a sentence here, which I think reflects most of the thinking in the field, that therefore from available evidence it can be concluded that recent rates for both autism and autism disorder are 3 to 4 times higher than 30 years ago. But at the bottom here, I don't know how well you can see it. I can't see it very well on this screen. Claims about an epidemic of autism and its putative causes have the most weak empirical support. So it's an ongoing debate, but I would say it was a more intense debate 5 years ago than it is today. Well, what about if there is an increase, what are some possibilities? I already mentioned vaccines and thimerosal. I want to just show you 1 or 2 slides about prenatal ultrasound. There's a publication from a person at Yale that suggested that prenatal ultrasound in mice can cause difficulty. If you make a whole list of possible things, many of them will be things that have changed in obstetrics over the last 30 years. Antenatal steroids to try to get lung maturation in infants who are delivering prematurely, epidural anesthesia, magnesium sulfate. I'm going to come back to maternal and paternal age. Can you all see the purple part of the lettering there? I can't see it much at all from here. That's more of a genetic issue, but it's something that if everybody waits till later to have their children, this could certainly affect the frequency of certain kinds of disabilities. Drugs to prevent preterm labor. There's a drug, terbutaline, that's used quite a lot. That there's some studies about toxicity in rats that are a little bit worrisome. There's, of course, a lot more assisted reproductive technologies than there was 30 years ago, and as I've already mentioned, we're all exposed to a huge amount more in the way of chemicals in our environment than we used to. And, of course, dietary changes occur as well, and folic acid or folate deserves maybe special mention. So this is an article from a couple of years ago about prenatal exposure to ultrasound waves impacts neuronal migration in mice. And what they did is they took mouse brain when it's developing, and certain cells are going to start out here and they're going to migrate out to this area. And these are normal at the top here. You see these red cells that started down here, now they're going up and they end up here in particular layers. Whereas in the mice treated with ultrasound, there's some cells that never get up there, and there's more of an irregular pattern to where the cells arrive. And so I think there's been some feeling that unnecessary prenatal ultrasound, sort of as a video at the mall or something, is very ill-advised, and that we should be cautious about things like prenatal ultrasound. But you could come up with a list of half a dozen things at least that were equally good candidates. So you could put down here, increasing use of prenatal ultrasound. I also said I wanted to mention folic acid. We have increasing use of folic acid in vitamins and cereals, and eventually fortification. In the early 70s, it was illegal to put folic acid in over-the-counter vitamins. Now, of course, it's in most over-the-counter multivitamin preparations. And there was concern that, or not concern, but there was evidence that increased intake of folic acid on the part of women prior to conception and during pregnancy would reduce the frequency of neural tube defects, spina bifida and the like, and it definitely does reduce that risk. But we've had a progressive increase in the amount of folic acid in our diet, and since the late 90s, the food supply has been fortified, and I guarantee you all have much, much higher blood folic acid level and folic acid levels in your body than you did 15 years ago. Part of the reason to be interested in folic acid is that there are genes that can be subject to chemical modifications, and this is just an example where there's a gene that affects coat color from a yellowish to a brownish color, and there's DNA methylation that's associated with more DNA methylation with the brownish color and less with the yellower color. You can take a pregnant mouse and feed this mouse a diet that's rich in folic acid and related metabolites and influence the coat color of the offspring. So we know that there are certain circumstances, they may be a lot more common than we currently have data, where the folic acid and related metabolite intakes can influence gene expression. And so I've worried some about the possibility that maybe high intake of folic acid is decreasing the rate of neural tube defects, but maybe increasing the rate of autism. I think this is not a big worry, but it's just there are these things out there that we don't have as much information as we need. And then chemicals. There's a person at the Mind Institute, Isaac Pessa, who has made summarized in very impressive ways and about the enormous exposure we all have to chemicals. It's absolutely frightening to listen to his presentation and hear about all these terrible chemicals that we all have in our bodies. And then there's any number of things. I thought this one I consider to be a bit of a joke, but does television cause autism? There was actually a fair amount of attention about this, and whether if you lived in Oregon where it rained a lot, you were inside watching more television and had a higher frequency of autism and so on. So all of these things, though, are relatively speculative, but we do know a lot of genetic causes of autism. Well, why think about genetics in the first place? Well, there are twin data that, in general, suggest that 70 to 90% of the time, if one identical twin has autism, the other identical twin will have autism as well. So this suggests some kind of genetic factors, but many different genetic mechanisms could do that. You have also risk in siblings is increased. So if a couple has a child with autism, there is an increased risk of autism for future children. It's getting to be thought to be slightly higher than had been appreciated in the past. This suggests that the parents really carry something. This kind of thing here does not necessarily mean that parents have anything. If you took Down syndrome and took twin data, you would have identical twins with Down syndrome. 100% of the time they would either both be Downs or not. So you can have things that, the parents don't have Down syndrome, but there has been an error in the formation of an egg or a sperm that has led to the birth of identical twins who have the same genetic change. Risk in siblings only will happen if the parents have something that they can transmit more than one time. And I'll just say that genetics can be simple and complex, and I particularly want to mention a little bit that it can be ancient as well as recent, or even de novo, meaning that it's new in the child with autism. And I'll just say a word in passing about epigenetics, which is an intriguing area which is getting increasing attention, but its relevance to autism is relatively speculative at the moment, although it's an area that I have particular research interest in. Now, I think you're all probably aware that there are many genes in the population that are ancient. We have millions of people with cystic fibrosis or gene carriers for cystic fibrosis and sickle cell anemia, typically Europeans having more cystic fibrosis and Africans having more sickle cell anemia. These mutations are ancient. They happened centuries and centuries and centuries ago, and these people on the planet are all descendants of these very rare events that happened a long time ago. And there's a lot of this kind of genetic difference in the human population. Pharmacogenetics works this way. You may know that you may hear talk about if you are going to be put on an anticoagulant like Coumadin, they may want to do a genetic test to decide what dose will be best for you and so on. And these, again, are ancient mutations that have been around for a long time. And childhood diabetes is like this as well. You inherit certain combinations of genes that increase the risk of childhood diabetes. There can be environmental factors, probably viral and so on. With childhood diabetes, you have a very high so-called concordance in identical twins. That is, if one twin has childhood diabetes, the other is quite likely to, but it's nowhere near 100%. So there are other non-genetic factors at play. Now, there are other things that are happening instead of centuries ago now. And Down syndrome is the best example of this. It's trisomy 21, or an extra copy of chromosome 21, causes Down syndrome. This is constantly happening in the population as a new event, The parents don't have Down syndrome, but in the formation of the egg or the sperm, there is this genetic error. And you're probably aware that older mothers are at increased risk of having this kind of event. So this would be called a de novo event. Again, it is genetic because the chromosomes and the genes determine whether you have Down syndrome or not, and you would have 100% agreement in identical twins. We have other disorders that, like neurofibromatosis, that's one of the disorders that's quite common in the population. Hemophilia is a disorder you probably have heard of, and Rett syndrome has been mentioned. All of these don't occur necessarily de novo in the patient, but they occur recently in the family. In the last 2 or 3 generations, this abnormality has appeared in the family. And it doesn't hang around because evolution selects against it. That is, if you have any of these diagnoses, you're less likely to have as many children as if you were a healthy individual, but then new cases start coming up again. So there's this constant new arising of mutations. It seems like the autism we understand is much more in this category of relatively recent events, not events that happened centuries ago. And there are kind of 2 possibilities. This would be de novo in the sense that this boy has a genetic change and the autism, say, that is new in him that neither of his parents have. But here you could have the event happen 1 generation earlier, and the father has a genetic change, and he might actually be normal, or he might also have have something on the autistic spectrum, and then he has this child. But it's not like it's been around for 10 generations. Now, when you think about these kinds of events, they can take a variety of forms. One is they can be a really big event in the DNA. So we all have like 3 billion letters in our DNA code, and if you take away 1 million or 5 million, this can be a deletion, and it can take away an entire gene. So this is kind of a large de novo deletion event, and these are the things that we're discovering the most frequently in autism. So there's rapid progress in increasing detection of these kinds of abnormalities contributing to autism. Now, these same genes could be inactivated by a 1-letter change in the DNA. This would again be a de novo or new genetic point mutation, in this case, just changing 1 letter in the DNA. We know this kind of change is associated with older age in the father. We don't have a good way to find these changes at the present time, because ideally you'd have to sequence the entire genome of these individuals, which is what will be happening soon but isn't happening yet. And then there's these epigenetic possibilities where there's no change in the letters of the DNA, but there is a change in the mechanism of whether the gene is active or not. So you could the gene could be there and have all the right letters but be turned off. And I say this is speculative. It's something we think we might need to put more research in on. This is an article about advancing paternal age. So the offspring of men 40 years or older were 5.75 times higher, 5 times more likely to have an ASD compared with offspring of men younger than 30 years. So this suggests these are recent events. These are events that's happening in this man's sperm that leads then to the conception of the child who has the autism. So I think this all fits with what we know. We don't exactly have all the facts on the advanced paternal age story. So you're probably aware that we've had chromosome testing for a long time, and if you did a chromosome test and you cut out the pictures of the chromosomes and line them up, you can see these chromosomes 1 through 22, and then here 2 X's for a female or an X and a Y for a male. So here you can see Down syndrome. There's an extra chromosome 21 here. You can see really big things, or if there's a half of a chromosome missing, you can see that's a problem. But in the last, say, 15 years, we've begun to use a procedure called FISH to show and to take a bit of DNA, to color it with a particular color, and then ask it to go find its match among the chromosomes. And what you can see here is green is identifying a particular chromosome, and I don't know how well you can see it, but there's red here, indicating the presence of a particular region. Let's say that if you're missing this region, it might be associated with autism. And here we see a chromosome that doesn't have the red region. Okay. Now, in addition, it can be troublesome sometimes if you have extra copies. So here's a similar, this FISH for fluorescence in situ hybridization. Here's the green for the particular chromosome. Here's the red for the normal chromosome. And now we see 2 dots for the abnormal duplicated chromosome. These kinds of changes are being seen with increased frequency in autism, or recognized with increased frequency, not because they're happening more often, but because we have much, much better tools now to look at this. Now, I have this disclosure here because our department has played a major role in bringing these array tools to the clinic. We started back in 2004 and have had a really major role in introducing this across the country. But we do, of course, like any medical practice, we do generate revenue from this, so you can envision a conflict of interest on my being here. So what we do is we take a patient DNA and we label it with a green dye, and a control DNA and we label it with a red dye. And you mix these together, and if the genome is the same in both of them and you mix them together, you get this yellowish color. And then we actually lay it on a glass slide with these bits of DNA. We started out with rather large chunks of DNA, but now we're using very small amounts of DNA. And if there's extra copy of the region in the patient, there'll be more green than red, and you see this greenish dot. And if there's a deletion in the patient, there'll be more red from the control and less green from the patient. So yellow would be normal regions of the genome, where it's a match for the patient in the test case, whereas green or red would show a gain or loss of copy number in the patient compared to the control. Currently, we use an array for regular clinical diagnosis that has 105,000 spots on it. This is the equivalent of doing 105,000 FISH tests at once. So you can see how enormously this increased our diagnostic potential. And actually, we are routinely, for research purposes, using arrays that have millions of oligonucleotides on them. So when we started out, this would be what the array data would look like. This would be an old-fashioned karyotype with 3 copies of chromosome 21. We put the DNA pieces from chromosome 1 on down through 20, 21, 22, and if they fall on this center line, there's an equal representation in the patient and the control. But here you see in this individual, there's a shift of all these dots are over here to the right, showing that there's extra copies of chromosome 21 in this sample. So this is sort of what the old test looked like, and this is what the sort of medium test of 3 or 4 years ago looked like. And This is now just switching that display horizontally, chromosome 1, 2, 3, and you see when you get down to 21, you can see there's all this extra material. Up means extra material and down means less material. And actually these chromosome analyses done this way are much easier to interpret than the, the historical method. So this is the sort of what started happening 4 years ago, not specifically with autism patients, but often with patients with more severe disabilities. Here a child with bilateral cleft lip and palate and poor growth and congenital heart disease, and the chromosome test was normal, normal female result. But when you did an array with our early arrays, you could see that in the region of chromosome 1 here, there was a shift to this side, which in this case is a deletion, whereas the other chromosomes were normal. But if you use the oligonucleotide method, now we're looking, instead of all of chromosome 1 is right up here. Now this is all chromosome 1. We're looking at chromosome 1 in great detail, and every dot is an oligonucleotide. And what you can see is the center line is here. This is the normal region, but you can see there's this big shift of dots here. And actually, if you reverse the die and do the experiment twice and put some kind of a running average across this, you can see here how cleanly the abnormal or deleted region is demonstrated by these kinds of array tools that we have now. This is an example of the kind of thing we encounter. If you look at this array, this child has a huge deletion here. There's no trouble seeing there's a great abnormality, and actually I could train probably a high school student in a half an hour that if everything stays on this line, everything's fine. If there's a big bunch of stuff below or above, there's a problem. Okay, and so you can see this is so easy to interpret. You see this gross abnormality. Well, if you take the chromosomes, it's very hard to be sure if there's any difference between these two chromosomes, and oftentimes laboratories would report them out as entirely normal. So we find now just a whole lot more information, and in this case, we have come with a FISH test and confirmed that the red is present on one of the chromosomes, but not on the other deleted chromosome. So we call this chromosomal microarray analysis. It goes by 2 or 3 slightly variation names. And I think it's a spectacular success. There's a 3-fold increase in the identification of the cause of the abnormality in patients coming in with mental retardation. So if you had a child with mental retardation 10 years ago, maybe we could identify the underlying cause 5% of the time, and now maybe 15 to 20% of the time. And it's given us general insights into many birth defects where maybe mental function is normal, but there's heart defects or limb defects and so on. It's been a major breakthrough in autism because we've gone from maybe 1 or 2 or 3% of the patients where we could identify the underlying abnormality to now a good 10% of the patients. And as I'll show you in a minute, this method has opened the door a crack to schizophrenia. Now for the first time we're seeing genetic abnormalities that most of us are pretty convinced are the cause of an individual's schizophrenia. We've run 20,000 of these tests. 2 of our faculty members left and started a company. They've run 30,000 of these tests. And it's really transformed our ability to make diagnoses in the genetic clinic. And I think it brings to the clinic a test that's really worth performing in autism patients. Now, I'm going to describe 2 faces of autism. So this is one end of the spectrum, maybe close to the boy we saw in the video. This child is normal looking. He's male. Time magazine was commenting about the possibility of the number of new cases is exploding, which again I would say is not so certain. But this is the normal appearing, high functioning child who has speech, probably tests out in the normal range, and about 8 to 1 of these children are male. So you heard that 4 to 1 is the average, but for the high functioning patients, males predominate even more than in the average. And I would say the cause of this kind of autism is pretty much completely unknown, although a lot of us suspect there may be some more subtle genetic lesions going on. We certainly don't have any proof of that at the present time. Now this is the other end of the spectrum. you can see these children are all quite severely impaired. If you saw them in your daily encounter, you would recognize that they don't appear normal. We sometimes use the term dysmorphic to mean unusual appearance. All of these children are in the mental retardation category, and all, this is a paper published from Europe, all were diagnosed as having met the criteria for autism. Now, it gets really difficult to make a diagnosis of autism in a totally satisfactory way for individuals like this who have relatively severe impairment. Now, here the male to female ratio is more like 1.5 to 1, and it's actually, I think, 4 girls and 4 boys in this photograph. And they all had abnormalities that were picked up by arrays that were not detectable by routine chromosome analysis. Now, this group of children, I think you can look at them and suspect that they're not likely to have children of their own just by your impressions of their appearance. And that would be right. And their parents will typically be entirely normal, and they have a de novo event. So something happened to a gene chromosome in the course of transmission from the parents to the child. This group of patients, we actually find an abnormality in 25 to 30% of the patients. And we think if we could sequence the genome in these individuals, we would probably find an abnormality in 80 or 90% of them. So these children, I think it's increasingly clear, this very severe end of the spectrum mostly do have underlying genetic abnormalities. Sort of maybe a quarter to a third of them are in a size range that current technology allows us to quickly find, and the others are probably single letter changes that would require sequencing of the entire genome to find the change. So I've sort of here tried to depict the severe end of the spectrum with a male to female ratio of 1.5 to 1, and the mild end of the spectrum, but there's a lot of children in the middle, and I'm going to show you some children who are in the middle here, some photographs in a minute. So recent genetic events or de novo events are playing a big role over here, and I'd say over here we don't know what's going on. Maybe it's genetic, maybe it's ancient genetic, maybe it's new genetic, maybe it's epigenetic, maybe it's environment. Over here learning is good, learning is poor down here, and the unusual appearance is present at this end and less so at this end. Now, we've made many new discoveries with arrays, and some of them are highly relevant to autism. It used to be we could find missing dots on FISH tests, but they were rarely done in a way that would detect a duplication or 2 dots. But it turns out once we started doing these arrays, we saw there were a lot of patients that we were missing. There was a patient described in the New England Journal of Medicine as the first ever with a duplication of the region that is involved in Williams syndrome back 3 or 4 years ago, and we very quickly were able to identify a number of similar children. Now, I would say these children are in the middle. They're not at the severe end of the spectrum, and they're not at the very normal-looking end of the spectrum. You could debate about whether they have slightly unusual facial appearance or not. I think we feel like they have some subtle facial differences. They have varying degrees of language and developmental delay. Many of them have autism spectrum abnormalities. But there's another kind of issue here, is that some of them have a parent who has the same change, and it has the same genetic change. So it's not new in the child, it's also present in the parent. And that parent may be entirely normal, or that parent may have had learning difficulties when they were growing up. So you start to see this sort of middle ground, okay? And you can see that they're not always new in the child, they may be present in family members. So in this middle ground, you start to see that these children look like they could conceivably be well enough to go on and grow up and have children of their own. And then, of course, there would be a considerable risk of having another child with this condition. But again, not every time you have the genetic change are you abnormal. Sometimes you're perfectly normal. We heard about the Rett gene, and there's a particularly common change in the Rett gene where there's an extra copy of the gene in males. These are very severely impaired children, as I think you can see from this photograph. This would be the severe end of the spectrum. And this child at 1 year rolled over at 7 months, could not sit alone at 1 year, has growth problems, microcephaly, a small head measurement. And I'm sort of surprised that as many of these children come in with a diagnosis of autism because they're so severe. This is what the array looks like. The Rett gene is on the X chromosome, and so we're down here on the X chromosome, and you can see there's this extra upward deflection, which is extra material. And I don't know how well you can see there's two red dots and one green dot down here. Sarika mentioned that you can have females who carry this trait, and this is an example of where the diagnosis can be very important because there can be very high risk of multiple affected individuals in the family with this X-linked or sex-linked disorder. Most of the children with this disorder die between 10 and 20 years of age, and these strikeout lines indicate all of these are deceased except this child who's still alive at the time this pedigree was prepared. Autism in general, this is a slide I put together some time back. Probably 8 to 10% now of children that we get a sample where there's autism mentioned on the lab slip, no formal diagnoses, we're able to identify an abnormality that seems to be the cause of the patient's problem. You see, there's 4 males with this MBCP2 duplication, so it's the most common finding, although you can see it's a very severe disability with a lot of encephalopathy and seizures. And there are a number of other things which we now see relatively often. This particular deletion of chromosome 16, so-called 16p11.2, is probably one of the other very most common deletions. This is being seen in quite large numbers of patients with autism. And they don't have very much in the way of other distinctive features, and I'm a little unclear, and out of things like the Simon study we may get a better idea of what the range of disabilities may be associated with this particular deletion. So some genetic conclusions about autism. There are at least dozens and more likely hundreds of genes that when damaged can give rise to autism. In most cases that are currently understood, one major genetic change causes the autism, and it has arisen relatively recently in the family. It's not centuries old. And the more severe and complex the disabilities, the more likely that a genetic change will be identified. So if you take a child who's very high functioning and looks very normal, you have a lot more likelihood of getting a normal result back, whereas if you take a child with a lot of severe difficulties, you're much more likely to get an abnormal result back. As I've said, in most of the severe patients, the change in the gene is usually new, and the parents are normal, and the individual is unlikely to have children. With medium severity, there may be a few family members with the same genetic change, and these individuals may be normal or may have a range of learning or behavioral disabilities. In the mildest patients, there's a particularly strong overrepresentation of males, as I've said, and we understand the causes the least. Genetic testing for autism is potentially complex, but the array test is sort of the really big yield, and although you can do a variety of biochemical and other kinds of tests, the array test has come to the fore as the major test to identify the cause of autism in a child. And of course, I've already said there's probably hundreds of genes doing this, so that there's all these different forms of autism. I want to tell you now just about, to wrap up with one short story, there are now at least 3 genetic deletions or regions of the chromosomes when missing that can cause mental retardation, autism, bipolar disorder, or schizophrenia, or leave the person completely normal. Now, we would have been incredulous even as recently as a year and a half ago if you had tried to tell us that there's this one genetic event. It can give you any one of these things, and actually epilepsy is left off here by accident, that it can be so variable, and that the same genetic change could cause schizophrenia in one family member and autism in another family member. So at least in some rare cases, there's more of a link between autism and schizophrenia than previously thought. So one of these deletions, we've had a chance to study a number of families. We had 14 children in 12 families. The exact chromosome isn't important. All these children had a study done because they had one or another kind of disability. 6 out of the 14 had an autism spectrum disorder. 5 out of the 12 families, the children were in adoptive or foster care. And in information where we had the parents available, it was usually inherited. The change was present in a parent. We had only one of these 14 that had seizures. There, in other series, there had been more children with seizures. 2 of the fathers had bipolar disorder and learning disability. 4 parents were normal or near normal. And many of the unavailable biological parents had diagnoses of mental retardation, psychiatric diagnosis, or antisocial behaviors, maybe things like drug abuse and so on. So we're concerned that this particular genetic event may have a significant risk of association with various aggression and behavioral disorders. So although I've got permission to publish these photographs, I don't think they should be published because we're kind of concerned about the outlook for children like this. This is a boy who has this particular genetic change. His father has learning disabilities and bipolar disorder, and he states that he's not able to read children's books to his children. So here you can see it's sort of a middle severity, and we see more than one affected family member. This is a child who has the same deletion. His mother has the deletion as well. I've not seen her, but the person who has seen her says she is stone cold normal. So you can see here we've seen bipolar disorder, we've seen developmental disabilities, we've seen autism, we've seen completely normal. These 3 girls are very remarkable. They are full sisters, all given up for adoption at birth and all adopted by the same home. These 2 girls on this side may look a little off to you compared to this girl. She is normal. These 2 have the deletion. One of them has been diagnosed with an autism spectrum disorder and the other has not. One of their parents, the mother, has a diagnosis of mental retardation. We don't have any sample from her. We've not seen her. And the father has a diagnosis of schizophrenia with a lot of associated things going on. Because we have 2 children with a deletion, we can be pretty confident that one, but not both of the parents have this deletion. So in this case, what we're thinking is that the deletion here is on chromosome 15, and there's, say, a deleted copy of the region. There's another normal copy of the region, though. There's 2 copies of each chromosomal region. So we have this non-deleted or normal chromosome. And so we're coming down here kind of with a half amount of this material that we should have. We should have 2 copies, both giving us input, but we have only this input coming from this one. If this were somewhat variable, as is likely among normal people, that could have an effect on what's going to happen. Also, there would be many other parts of the genome where there's common variation which might affect this. And somehow out of this, you can come through and end up with mental retardation, autism spectrum disorder, epilepsy, schizophrenia, bipolar disorder, or be normal. So now we have one kind of major genetic change that's recent in the family, but there's a lot of other genetics going on that can modify how much difficulty this is going to be. So as earlier, we have a lot of people involved in our microarray group, and this is sort of like credits at the movie. You can start filing out, but it takes a huge amount of people to generate all of these kinds of activities.